Hello?
Hi.
Hi.
Hi, sister.
Evening.
Hello.
How are
Hi,
we all?
sister.
Hi.
Hi. Thank
How are
Fine.
we doing?
We
We
are
are
fine by
fine
grace.
by God's grace.
Yourself? Fine by God's grace.
Okay. So, me too. The Lord's grace is keeping. Let's pray. Father, in Jesus' name, we thank you for this evening. We are grateful that you have kept us and brought us together for this discussion. Holy Spirit of God, grant me utterance and the wisdom to teach. Let understanding be the portion of my students as we go through this evening's discussion. May your name be glorified at the end of our class. In the name of Jesus Christ. Amen.
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 Mercia Santua. Veronica Derry. Please mute yourselves. Okay, so please, the last time we were able to finish the changing roles, right? Can I have some response? Who is the class rep here? Is Nancy here? Hey, Mercy. Is Mercy a class rep? Mercy, are you a class rep? Yes. Or there are different Mercies in the class? Am I the only person in the class? Nobody is responding.
No, sister.
We can hear you.
We are here.
No, sister, we are here.
Okay, so were we able to finish last week's discussion on the, how do we call it? The roles of the midwife. We finished, right?
I
Is the
don't
one
think
I...
so. Yes,
No,
sister.
please.
Who said no?
No,
Please?
sister.
We did. Didn't we finish?
Did.
We
Yes.
finished.
We
Yes,
finished.
sister.
Yes. Okay. I've not sent you the slides, right?
Yes,
Yes,
sister.
Please remind me to send it to you. Class reps, kindly remind me. Okay. So today we are continuing. We are looking at new trends in prenatal care. This thing, almost everything here, we have heard something a little about it. So we won't be completely lost. Okay. Is it big enough on your screen?
Sister.
Yes, please.
Yes, sister.
Yes, sister. So when we talk about prenatal care, you are midwives, so you are very familiar with it. That is what in our setting we say antenatal care. Okay, so what are the new things that are going on? Traditionally, how was it? Now, how is it? So now they are saying there is something called ambulatory blood pressure monitoring. Hey, sir. Okay. So you can be walking around and then you'll be monitoring your blood pressure. At first, too, you have to sit down, Barry, like a midwife, like a statue for the midwife to check and record. So it looks like right now, looking at the picture, you can actually record and then your care provider can access it easily. Then we also have fetal heart monitoring. Hey, the mother, I thought it's only midwives who monitor fetal heart, isn't it? But right now it looks like the mothers can access it. There is this new device that's I don't know whether they've implemented it, so I cannot speak much to it, which they are using to monitor the mother's heart rate continuously, not even the baby. I don't want to talk much about it. When I realized that it has now been officially launched, we will talk much about it. So we also have self-measured symphysiofundal height. Really? Wow. I thought the midwife was supposed to do all this. So these are some of the things that are trending. You can actually do it yourself. So they are giving tape measure. They are shown where the fundus is, where the symphysis pubis is. They can lie down, take the measurements, okay? Then with the telehealth, they can impute it into the system, and then you'll be at the clinic and then you will view it. Things are going on. New things are coming up, and it is trending elsewhere, even if it hasn't gotten met. It's here soon. So by the time we are done with this few that we have seen, we want to be able to identify and discuss the few elements and benefits of personalized care. That means personalized care is also something that is what? Trending. We discuss its benefits, challenges, and then the way forward when it comes to telehealth and then remote care. Then we identify and discuss the advantages and disadvantages available for advanced imaging and technologies. Then we come to discuss types, benefits, challenges, and ethical issues of genetics counseling. So, of course, these are not so many. They are things that we know. However, we take our time and go through. So let's look at personalized care. What do they mean by personalized care? It may look like something so new and foreign, but it's not. It is what in our settings we will usually say focused antenatal care. You get it, yes. So in personalized prenatal care, okay, there is a tailored approach, and the approach is to the maternal and the fetal health. So it's just about not every woman who is pregnant, not every fetus, but that particular one seated in front of you, only you. This care is tailored to suit your characteristics. Because of your genetic background, we will do this for Madam A, but not Madam D. Because of Madam A or B's lifestyle, we will have to do this and not that. Their medical history, do they have any existing conditions, some environmental factors? So we put all these things together and we tailor. You see, the word is tailor. I don't know if I've seen any one of you before, but when you go to the tailor, there is no way the tailor will use my measurements to make a dress for you, because the tailor is tailoring you, making something just for your own body. That is why he's called a tailor, because he's tailoring you. So you too, if you're having a tailored approach, then it means that you are considering only that woman, Madam A. When you get to Madam D, you may have to change the approach. Abi Yuba. All right. So this type of care focuses on recognizing the unique needs of each pregnant individual and providing interventions that are specifically designed for them. You get it? Aiming towards improve both maternal and fetal health outcomes. Right. I've explained that already. So there are some key elements of personalized prenatal care. So you and I are here boasting that we too, the focus antenatal we are doing is personalized, is patient-centered. Okay. So let's see if you see these elements in there. Number one, Genetic screening and counseling. Do we really do that? So a mother comes to you and tells you that in her family there is history of gestational hypertension. In this slide, the examples are cystic fibrosis and then Down syndrome. So what will you do? You would have to let her undergo genetic screening and counseling early in the pregnancy. For what purpose? The purpose is to find out if the baby who is coming is at risk. Okay, so this can help her understand the risk and then consider early diagnostic options. So, okay, for this condition that you have, madam, it will take only heaven for your baby not to get it. All right. So she makes an informed decision based on that she wants to undergo some diagnosis. Okay. So are we going to do chorionic villus sampling using the placenta, or we are going to use the amniotic fluid doing amniocentesis? Whose name is that? Loco what? Loctima. Yes, mute yourself. All right, very good. So we do this, and then we are able to identify the risk, the level of risk. Okay, are we also looking at customized nutritional guidance? First one, the mobowa, you don't do it. If there is anybody here whose facility does genetic counseling and testing, please let me know. I know some hospitals do, but usually those hospitals tend to be private. Please, if there are any government hospital workers here who, as part of your focused antenatal, or even if it is not integrated into focused antenatal, and it is something you do at your hospital, please let me know. Anybody genetic counseling and testing? Or you work at a fertility hospital, private, do you see them doing that there? Who works in a facility where they do IVF? Hey, let me close the class. My students are not there.
Sister, we are
Madam,
So why are you not answering my question?
We are not working there.
Sister, they don't do.
Most of us are in chips,
In chief zones as well. After the degree, go and get some one locum at some. I'm getting feedback. Hello? Can you hear me?
Yes.
Yes, sister.
When I talk, I get feedback. So please, everybody mute yourself. Okay, sorry. So after this degree, I'm encouraging you to go and do, how do we call it? Some part-times in some high-level hospitals so that you get to see some of these things. All right. But it's interesting. They are interesting procedures. All right. Then number 2, we are looking at customized nutritional guidance. That one there, my mom and Sasso, you people do it, okay? So we have gestational diabetes or people who are at risk of preeclampsia. How do we call it? People who even have existing conditions be already, which demands that they undergo strict nutritional intake. I know, I see them, they do well. They refer them to see the specialist so that they are given what to eat. That will help them and what to avoid because it won't help them. And then regular monitoring of blood sugar levels, even by the patients themselves, we do it. And then regular blood pressure monitoring also. Yeah, so we encourage them to buy BP apparatus. There is this BP apparatus I used to have, and I know there are some there. It's like a wristwatch, very small. And then when you check your BP and your pulse, your temperature, it will tell you that the kind of BP you got is optimum, or it's pre-hypertension, or it's early hypertension. It was doing well. So these things will help us. Then we have tailored exercise plans. Myself, when I go for pregnancy school and then we are having this exercises, I usually separate them so that those who have done sacrilege, I will separate those who have done the sacrilege from those who have not done the normal pregnant women. Why? Because the exercise should not be general. If someone has done cervical sacrilege, Hawa,
Sisters,
Hawa,
please mute your mics.
okay. So I'll usually tell them these people are doing these exercises, these ones will not. Why? To prevent putting one at risk. Okay. So why did the person do sacrilege? Because there is threatened abortion. Okay. Maybe on account of incompetent cervix. So we don't want to stress the cervix. We don't want anything to aggravate it so that it will go into contraction. And because of that, you may have to be mindful kind of exercises that you make such a person do. So when it comes to the meditations, of course, they can join. When it comes to deep breathing exercise, they can join. But when I'm doing the squats, they cannot join. You get it? Even though we want them to be healthy, yes, we have to make sure that it's suitable for the particular person. Then we have personalized monitoring for high-risk pregnancies. So women with chronic conditions may require frequent monitoring. Okay, we want them to come to the hospital so that we monitor them. But of course, they can do some of these things themselves at home, and it all helps. All right. Then mental support. Yeah, this also has to be personalized. I can imagine how mental support can be done in general without personalizing it. Each client will need what? Different counseling from the other. So if a pregnant woman has a history of depression or anxiety, personalized prenatal care must involve what? Mental assessments. And you cannot do it in groups. You have to assess that person alone, determine the kind of therapy sessions they need, or refer them to see a psychiatrist. And sometimes too, they may need cognitive behavioral therapies, the CBTs, and then mindfulness. Mindfulness is a technique that is really trending. It's not only for, let me say, let me say that it has even been borrowed into midwifery, but it's a practice, it's an ancient practice, which is so good, being mindful. It's like taking care of your own problems, taking charge of your life, doing that which is right and which will help you. And it's very, very good. I was talking to a lady this evening who is actually married, but also in a relationship with another guy. And unfortunately, guy, the boyfriend, supposed to say is not treating her well. So I was like, why stress yourself? You are even the one sponsoring him. Right now, what is your basic need? Is it just about sex? She said, no. I said, if no, then love yourself. Okay? Love yourself first. If you don't, and you want to get the love from someone, it will always end up in tears. Just be mindful of yourself first. Put yourself in every situation, and it is called self-love. Give yourself the best. And the Bible even says that do unto others what you want others to do unto you. Love your neighbor as yourself. So you see, there is nothing like removing yourself. It is always yourself first. The way I love myself, that is how I'm supposed to love you. I'm not supposed to hate myself and love you. Do you get it? So these are things that midwives we are supposed to do. So for me, that is my community service. She's actually not pregnant, but she's a woman. And so she was referred to me. And that is what we are expected to do. Personalized care. All right. Then when it comes to drugs, pharmacogenetics, that one too has to be personalized. In fact, when I'm teaching at the pregnancy school and we get to drug abuse, I'll ask them, do you smoke? They'll say, hey, Auntie Grace, no. Do you sniff cocaine? They'll say, hey, Auntie Grace, how can we sniff cocaine? So when you are talking about all the hard drugs, they speak so innocently, and I trust them, they will not sniff cocaine. But I always have to top up with this knowledge that the moment you take a drug that has not been given to you by your doctor, then it is also drug abuse. Yes, so I'm doing the work. What do I mean? We would have to look at the woman's genetic variations, see how their system can metabolize a certain kind of medication and give it to them. And so you and I are pregnant, we all have waist pains. They gave you paracetamol, and within the next 6 hours, you are fine. They gave me paracetamol, and it's as if they gave me chalk to chew. I can't see anything. I can't find anything. You get it? So in this case, of course, paracetamol is analgesic, but because of our variation in genetics, you see, it's working for one person, it's not working for the other. So you would have to what? Build or tailor something, a medication, which is safe and efficient for that particular woman. Then we come to lifestyle intervention. For a woman who smokes or is exposed to high level of environmental toxins, whatever, mercury, aluminum, whatever it is, yes, you may need to personalize their intervention when it comes to nicotine replacement therapy, counseling, educational resources. You would have to personalize it. What the person needs is what you have to give, okay? And then sometimes we may not necessarily need to take them off completely because of withdrawal syndromes and rebounds effects and all that. We may actually want to help them minimize it because sometimes there is nothing that you can do about it. The addiction has gone so high. Withdrawing it completely may not may not be the best. So you may have to reduce it so that it reduces the exposure that the fetus will get. Then we also have cultural and then social considerations. And we have done this already. If you remember, we are talking about culture. So put the woman's culture at the back of your head. So this woman is contracting 5 in 10, 58 seconds, 56 seconds. The least crowd was 52. And the woman says she cannot bear the pain. And you tell her, so you are a knot now. Any nothing name, let me find one so that I'll use it as an example. Hey, Josephine.
Atempoka.
Yes, Eunice Salamatu Yakubu, who was mentioning an yes. So Salamatu is on duty, and you Salamatu, because in your hometown, when you are going to deliver, you are not supposed to shout. You are supposed to be quiet. This woman is screaming on top of her voice. And you tell her, hey, this one, hey, just try. You are just 8 cm. You deliver right now. All of us, we go through. Me cry when I was delivering. When you know you are at this point, you don't scream. You are going to use the energy to push your baby. You just endure the pain. Try. Try. You see all the other women here, they are quiet. They are also 8 cm like you. Hey, Salamatu, is that how you are? You are not respecting the woman's cultural background. As for the Ashantis, they shout, they shout and insult their husbands. You are using your northern cultural style to encourage her. Never mind. If she's in pain and she can't bear, how can you help her? It's contradictory to give something like ethidine at 8 cm. But at least sacral massage could be helpful. Even diversional therapy could be helpful. So, midwife Salamatu, do something about this pain and stop imagining women from the north in labor when this woman is from the south. I hope that is clear. Then personalized care would respect and integrate these beliefs whilst providing evidence-based recommendation. I think we've spoken about it at length, yes. So for you, you respect their beliefs, okay, but it shouldn't go against evidence-based practice. So another example, Sister Salamatu Yakubu. This lady is coming to deliver and she's wearing talisman. How does the talisman interfere with your delivery? Unless, of course, labor goes wrong and you want to prepare her for cesarean session. But if all things are equal, the talisman is. Do you know that delivery is not even it's not a sterile procedure? Some experts have argued it that it is a clean procedure, not a sterile procedure, because even the feces that are coming from the anus should contaminate your field if you think you have created a sterile field. It is no more okay. So, of course, look at the talisman. Is it very dirty? Is it smelly? Is something leaking from it which will smear the vulva, the area where you are doing the delivery? No. It's just one dry, neat thing they have tied there. Okay, will it impede descent of fetal head? No. So why do you want her to remove it? Just because you're a Christian and she's wearing talisman. In fact, that one, I don't think that is the reason. It is because you are afraid of what the talisman will do to you. Okay, so you may want to ask her, Auntie Memuna, this thing that is on your waist, is it possible for you to remove it? She says no. If she removes it, labor will be difficult. In her hometown, if you want labor to be easy, you put it there. Evidence-based practice, this is not something she's taking in, where you cannot tell the interaction physiologically, whether it's going to affect something or not. So she's not drinking anything. It's just a physical ban which will not obstruct anything. Please do we get it? And there is also an example here about a vegetarian who wants to receive specific advice Was it your class? I thought. No, the other class. So I was giving them an example on asking me to go and give education or nutrition to an Adventist. And then I start telling her eating foods that are rich in calcium, protein. And then I start talking about shrimps, snails, salmon, pork. Can you imagine? Okay, so that will not help. Okay, culturally, religiously, socially, that will not help. So I would have to shift from those ones to herrings, anchovies, meat, cartilages, because that one she can eat, the other one she can. Okay. So what are the benefits of personalized prenatal? So you want me to stop teaching and be muting you people? All right. So benefits of personalized care. Personalized care. So what? If you do it together, can they hear? They can hear. They should practice. No. When you personalize the care, it improves outcome. Look at the example I gave on my nutrition education to an Adventist. Because you are a health practitioner, she may even decide not to talk. Eda, you have gone to school and you are teaching her. So she can just be watching you and be listening. When you finish, you get up and go and eat what she used to do. You say, I didn't know this was the nonsense she was coming to tell me. I wouldn't have listened to her. Okay. So at the end of the day, she'll go and come back with the same problem or even worse. It empowers the patient. It's as if you have put power in their hands. The fact that what they want is what you are doing for them. What is good for them is what they are receiving, makes them feel so much loved and empowered, so much understood. Then we have targeted intervention. Okay. So when you identify risk factors early, clinicians can prevent complications and manage them. So when you personalize the care, you will see the woman's particular problem quickly. All right, because you are the same person caring for her. Any questions before I move on? No questions. Okay. So let's move on
to lots of normal beads and designer chains at the waist.
Designer beads.
Yes.
So did you ask her and she said it was just for fashion?
Yes.
Okay. And was it for cesarean section or vaginal delivery?
No, SVD.
Okay. Was it in the way of delivery such that blood will go around it? It will increase the woman's risk of infection.
It was just on the waistline, just
Okay,
below
so
the abdomen.
Abdomen. So
Yes.
it wasn't in your way.
No, please.
You easily do your okay. So did you let her remove it or you continued your delivery?
I actually cut it.
With her consent?
Yes, please.
And she agreed that you should cut it.
Yes.
So what informed your action? Why did you cut it? Since you said it wasn't in your way and it wasn't impeding or impairing what you were doing.
Traditionally, we know that they are not supposed to wear like beads and those things when the pregnancy is like, let's say 8 months or approaching term.
Eh, who
Yes,
said it?
my community, you don't do it.
Okay. Is the woman part of your community?
No, not really.
So why did you let her stop it?
Because we have been stopping them even from ASC.
Eh,
Yes.
okay. It's getting interesting. Is it a community thing or is a hospital protocol? I'm asking this because when I was in Kolebu, it was not allowed, even your hair do. As for that education, I was the one who used to do that education when they are in their third trimester. I'm the one who go and educate them not to wear nail polish, not to do pony, pony hairstyle, not to put beads, okay, those kind of things. I was the one who used to give that education. And why was that a hospital protocol? Kolebu is a referral center. So everybody is a candidate for what? Unannounced complication. So we don't want you to come to the labor ward with pony hairstyle. Do you get it? Then all of a sudden, labor gone wrong. We need to get you to the theater. Spinal anesthesia is not possible. So our only choice may be general anesthesia. And general anesthesia, before we do the intubation, we need to straighten your neck. But we cannot straighten your neck when that pony, the big hairdo is at the back of your head, is on your occiput. So we prefer that your hair is very loose. Because if you go and do something and it's so difficult for us to work, the only option is to cut the whole thing, throw it away, so that we can position your head and do it. And then the beads and things, we didn't want you to be in the labor ward, probably delayed first stage, delayed second stage. After we are coming to cut beads, pass catheter, so don't put it before you come, so that in the event of an emergency, we can quickly do what we want to do and get you to theater. If that is your hospital protocol, that is fine. Do you get it? Oh, who was talking? What's your name?
It's me, Georgina.
Georgina, yes. So, Georgina, if that, you see, at this level, you can always talk around something, even wrong things, you can defend them to be correct, depending on where you are coming from. So, you see, the same bead wearing, when you go elsewhere, outside the country, usually those things, they are there. Because there they can easily determine whether you go for CS or not. Do you get it? And even if you go for, they won't let you get into labor in the first place. But here, sometimes the woman will even get into labor before coming. So, Georgina, let me get your point clear. From my example, is yours a hospital protocol or is a community way of life?
Sister, it's not actually a hospital protocol. I think it's much of a community way of life than something hospital. Because
So
from my village, we don't.
Which village? Which village?
I'm from Chito in the Volta region.
Chito, okay.
Yes, and that place you don't wear beads like when you are pregnant and especially when you are pushing delivery.
Okay. All right. Okay. So of course, they may have their cultural explanations to it. Me, if you ask me, do you know what I will say? I will say two things. Probably the ancestors believe that if you put beads, it will press your baby's nose, like the way down here when you are pregnant and you wear trouser. If you pass by 5 old women, 3 of them will tell you that the trouser is not good for your baby. It will press the nose. The baby can't breathe. You get it? All right. And then another reason too, when you wear beads on your waist, you are very attractive, isn't it? But when you are pregnant, we don't want you to get so much attractive to, your husband coming every day, pam, 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 pam. Before we realize, you may have even aborted, you get it. So maybe the old folks may have their reasons, but when you bring it into health, for us, it's about infection prevention and then emergency control. So I think those in the Volta are not so. Georgina, do you agree with me? Do you think it's a bad practice?
No, it's not a bad practice.
All right. Well done. Someone's hand is up. Who is that? Has the person put a hand down? Oh, someone raised a hand. All right. So, Lydia Aka.
Hello. Please, mine is a question. Sister, my place. There was a time this lady came. She was having some red band on the waist. During the review, I had said to move it. In the process, it was labor. She first time attending to her. So I asked her to remove it. It was labor for 2 years. Then she said, when she remove it, she would die. And I'm saying, and I said, this one is not true. Madam, remove it. It was the first one. She delivered at the Nakaba garden because she nearly died. So she delivered there. So this one, the Nakaba woman is dead. So this one, she wants a different place. Then it was also the same, it said it's the same thing. So they put it at the waist. So she came and I said she moved it. I said, Madam, yeah, me. I said, do you trust in God? He said yes. Then I said, if you trust in God, what you are, I don't believe it. So if I believe like that means I'm wrong. So please move it. I commit, like I told her to move it. She nearly denied it. So it was ACM. I said she move. She said, oh, madam, I let her move it because me myself I was afraid. Did I do the wrong thing? Thank you.
So I was right when I said that sometimes you make them believe it. Sorry, you make them remove it, not because it's against your belief or hospital protocols. It's actually because you, the midwife, you are afraid. All right. So then it means that in removing it, she wasn't happy. She did it resentfully, isn't it?
Sister, yes, she did it, but I pray with her. I tell her God can do anything. Even though I was not, I'm not prayerful, but that one, we didn't pursue. So I prayed with her. She moved it. Then she had a successful delivery. Nothing
She
happened.
didn't die.
Then, no, I mean, that for 6 hours. Then I discharged her. So once she was going, then she forgot the district. I said, Madam, I said, Madam, someone where she are near me.
So you see, I don't know which. So that is what they may have told her right from the beginning, that thing has to be on her waist. If not, she would die. You get it. But in your case, you are blessed to have a client who cooperated. I think in some circumstances, if they insist that they will not, you may also have to let them know what your fears are, that probably you are afraid. Then the two of you will come to an agreement whether she will choose to go to a different place or allow a different midwife to do it for him. There are some dilemmas that you have to be tactful when you're handling it. You get it. You have done well. Next time, don't be afraid. Just as you wanted to believe in God, you to believe in God and do the delivery. All right, so that was a good contribution. Well done. Can I go on?
Hello, sister.
Yeah. Yes, please, I'm listening.
Normally protect them. That's their belief.
So when they come to their go for normal delivery, STD, I cover it. I just cover it with their courses or their club. Because some will tell you that is what is protecting them. If you try to explain, understand, most of them are difficult. So I'll just cover it with a cloth because
so your strategy too is good. You just cover it and then you do your work. Very good. And they cooperate with you in that sense, right? I can't hear her again.
Yes, please. They cooperate with that.
All right. So please, let's take clues from what they are sharing with us. When you get to a situation whereby your practice is conflicting with the client's cultural practices, take the appropriate decision. If it is difficult for you to make such a decision alone, there is no harm in calling onto a senior colleague to make such a decision. Like as to you cover or you will cut, or during ANC cry, you tell her that they shouldn't bring such things to the labor ward. You have done well. Clap for yourselves. All right. So all right. So let's see telehealth and then remote care. What is telehealth? Telehealth and remote care. So I spoke about it. Elsewhere, it is the order of the day. Down here, we are still struggling with it, but we'll get there small. I have a colleague who did her master's thesis in mHealth, how they are going to develop text messages to remind women of their ANC visits. And I think that's a step forward. Then we have it being more common or its usage increase with the incidence or the event of the COVID-19 pandemic. In fact, all this online that we are doing with you, it was there, we were doing it small, but until COVID-19 came, was not so much like we are seeing it today. With the introduction of COVID-19, tools had to now open their 1,000 on Zoom right now. Some years that much. Couldn't have taken it. So both technology, okay, and then let me say incidents of pandemics and all that have helped us, okay, to come out with the best to serve people far and near. And I think we have to continue it. We shouldn't stop. All right. So let's see. When we say telehealth, it's broad. So we are looking at telehealth now, not remote. It's a broad term that covers use of technology to provide healthcare services. So this is telehealth is what? Technology. All right. So as to whether it's education like you and I are doing, what we are doing now is tele-education as to giving information on healthcare services. And it has ranges. Some people will say it has types. Okay. So what are those who are making noise? When I want to mute you, then my slides will be changing. Okay. So we have what we call telemedicine. So telehealth is the broad umbrella. Okay. So telemedicine can be under telehealth, okay, specifically to remote clinical services. So when we are going to some villages to do consultation, diagnosis, treatment, so it's like a small hospital, okay, that we are doing. Okay. So in some village, they can call us, okay, wherever we are. We can also call them, whether voice or video or text message, and we do consultation, diagnosis. So it's like, let me say you are in your home and you are receiving care, or the hospital has come to your home. And then with that, okay, depending on what the clients say, you can be able to evaluate the symptoms, prescribe medication. And because it is video, personally, when mothers call me and they tell me my child has this, I tell them, once I have not seen, I will not be able to make a proper diagnosis and tell you what to do. So take the child to the hospital. But sometimes, even when they take pictures, videos, because they have to zoom in and all that, they are so big, or the image is distorted, so you are not able to make a good judgment. So you refer them. But when it comes to those doing telemedicine, they have sharper apparatus for that, okay, and then they can communicate easily. All right. Then we have remote monitoring, like we were talking about the BP apparatus, which is ambulatory. Okay. So you monitor yourself, you wear it, you monitor yourself, and then you transmit the data to the healthcare provider. So you will do the monitoring. Since it's an electronic technology, your findings or whatever you got, your results, can be connected to your phone or your laptop, and then sent through whatever link or database you have been given, and then they will receive. All right. Then we're also saying that it is very good when the disease condition is chronic. Even in hypertensive diseases in pregnancy, there is what we call chronic hypertension. That means that the patients already had the high blood pressure before pregnancy set in. So these ones, they are chronic, they are living with it, heart diseases and all that. They don't need to be coming to the hospital every day. No, they can just do that. You monitor it. When it's going wrong, you call them to come to the hospital, right, for further management. Then we have mobile health. Okay, what do we mean? Mobile app and devices, okay, such as fitness tracking, mental health support, medication reminders, all fall under what? Health. So these tools, what do? Let me say they empower self-care. In conclusion, they empower self-care. That the patient can sit at home and manage their own health issues, of course. All right. Then we have teletherapy and mental health. What do we mean? Telehealth also extends into mental health. So of course, you have not even used your eyes to see the patient. So is it counseling? These ones, they all have their disadvantage. You go into it. An example is what I encountered this afternoon. At a point, the lady was crying so much. She was crying, and she's alone in the house. And she's just crying as she's talking. She's just crying. She's just crying. And I told her, oh, it's unfortunate I'm not around you. At this point, I should be able to hug you, wrap your back, give you a shoulder to lean your head on. But even though I'm not there, don't worry. I want you to go for a glass of water. Don't gulp it. Don't drink all guna 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 at once, Sip it as gentle as possible. You can get a glass of drink or juice. And I know it will be difficult for you to sleep, but just lie on your bed, and then let the body rest. With time, sleep will carry you away. So please, do you get the difference? So yes, when it comes to particularly teletherapy and mental health, that is my only thing with it. But it's good, at least. There can be a video session where you can talk to the therapist. All right. Then we have health education, which could also be done for patients. You educate them. It can be online, webinars, visual. Workshop. And what were benefits? What do we get? Yes, it's easily accessible. I mean, you don't need to take lenient, right? Then cost effective. If I'm moving from here to, let me say Tech Hospital. Tech Hospital is the closest to where I stay. From here to Tech Hospital, I need 8 cedis. Okay, so in and out is 16 cedis. Hey, it's money. Almost 20 cedis. That is a lot of money. So what if I don't have 20 cedis to go there? And when I'm going home, I'll see what I will drink. I may buy something to drink. That is cost on the part of the patient. What about the provider? I don't need to build a hospital. Look at the amount of money that goes into building and all the gadgets and things. All she needs is to be talking to the client that is there. Okay, you may need to build. Don't disturb my class, Matilda. You may need to build something so that when the case goes by, the client will come there. But of course, because you are doing more of telehealth, if the clients who you see are 100, okay, then you may need 100 chairs at your reception or the OPD. But in this case, a lot of the times you are doing telehealth.
People do, yeah.
Health, unless one rate sends to you and you think it's not the best share, and you may not even be having 10 clients. So you can buy only 10 and waiting. Yes, and you yourself too, you may have to move up and down because of that. But if you also have your gadgets, you are good to go. All right, so I've explained all that. Then efficiency, quicker consultation. Hey, you call your doctor right now, he'll pick. If you walk to the hospital 2 hours, you will see care, especially those on chronic condition are caring for you. Okay, so not the one that will say client defaulted, client was not coming to the clinic again. No, this one there is smooth continuing. Will continue to take care of the client. Then patient empowerment, very, very important. She herself can use digital BP apparatus. Those ones, when they talk, they are more than doctors. So the patient feels in control, she feels empowered, she becomes more knowledgeable as she's using those things. And then it actually even promotes proactive health management. So when she checks and is high, sometimes before she even calls you the midwife, she may have done something as first aid. Do you get? All right. What are the challenges as we were talking about? Technology access and literacy. BBC born before computer. they will use it. They want to come and see doctor. They want to come and see midwife. Internet connectivity, like you and I are suffering. The class we had at all drop. Okay, all those things can make the work difficult. All right. Then quality of care concerns. I was giving you an example of some of my clients who will take pictures or call me about their babies, and I tell them to take them out to the hospital. So of course, I'm not some small heat rashes, which will do in such a way that I'm missing helps. And I was also giving you an example of clients that I wanted to give a shoulder for her to cry on. So my care, the way I wanted to give the care, it didn't come out the way I wanted it. And it's not as quality as I wanted it to be. Why? Because it was a virtual discussion. Then data privacy and security. Yeah, as for us here, we don't have so much of that. But in the US and elsewhere, they have policies governing all these. Because before you, where are you? You are at where? Nablongo, and I'm in Kumasi. So to get your data, it means your data was flying in the air with wings. What if somebody caught it in the air? So you and I, we are not even bothered because nobody needs our information for anything. Let's assume that the President Mohammed's wife is pregnant. Hey, at her age, where is she taking the pregnancy to? Hey, why? You know, everybody's gossiping about it. She looks pregnant. She's not pregnant. Only for one day. And then Lordina Mohammed's name popped out. 24 weeks pregnant. God forbid. So she's monitoring her BP constantly in the house and transferring the information to a health practitioner so that she doesn't even need to walk to the hospital. Someone has hacked into the system and had access to it. It is a breach, data breach, and privacy violation. So Ghana, dear, we don't care about such things, but elsewhere they do. Reimbursement and insurance. Now that I have spoken to you on phone, how will I take the receipt to my workplace that I was sick and I went to the hospital? So the insurance should pay. My workplace should refund my money for me or reimburse me. How do I get the receipt? You send me what's the electronic receipt? Yeah, right now a lot of people do. They will send you electronic receipt and probably you print. All right. Then we have what do we call it? Regulatory and the licensing issue. So you called the facility, that's fine. But who picked the call? How sure are you if the person has the requisites license to practice? I'm a midwife. I finished degree at Garden City University. Okay, nobody is arguing that. So you have the certificate for midwifery. But where is your license? Probably the one who do that, I have to shout.
Ma,
Okay. So yes, I have certificates from Garden City as a degree midwife, but I need to pass my licensure exams to be given license to practice. I don't have it, and I'm sitting behind computer where nobody knows who I am, and I'm just giving management here and there to people. So who is regulating the system to know who qualifies and who doesn't? So that's also another issue. In the near future, what will become of telehealth and remote care? In the near future, it appears promising. You see, right now, as I'm even talking to you, I've put one leg in the chair and I am talking. Come and see my dress and my hair that I'm using to teach. It's a free world. Imagine I had to come to you in class. I feel I'm a mook. And then crochet, gather my hair together, perfume myself, look prim and proper. Travel from here to Garden City is more than an hour to get there. Why? When I could have done what? Technology far away from you. Do you get it? So the future is promising with ongoing innovations that is likely to enhance patients' care and accessibility, just like you are enjoying. And then it also looks like one day this technology we are looking at will invite Mr. AI for dinner. Because they believe Mr. AI is more accurate for diagnosis, okay, and then improved communication technologies like 5G. Yeah, I think 5G is in Ghana. Please, do you have phones that use 5G? I think mine is 5G. Hey, nobody is using 5G. My people. Who uses 5G? Akosia, you may be shocked that you are using it, but you don't know what you are using. So when I finish teaching, go to the settings of your phone and go to connectivity. Okay, when you go to connectivity, go to the internet and check which yours is. Okay, so mine has 5G lights. Okay. So it is the light version of it, and people are using it. Okay. Then advanced wearable gadgets. Okay, that one will also be there. Which right now there are a lot of them. There are common ones. Sometimes you see people going for jogging and they have their some devices that they are wearing on their arm, checking their heart rate and all that. And even me personally, when my phone came, it came with those things. So I didn't know it had it. One day I was there and then I got a congratulations. Every human being is supposed to walk at least 6,000 steps in a day. So I think that day I was in town, I did a lot of rounds and it sent me a congratulation message that I have walked over 12,000. That was 200 and something percent that they have really worked. And I was like, where from this? They said, oh, it's part of your phone. I was like, oh, really? That is fine. So in the future, this will be so easy that I could have easily just captured. It's actually checked my BP during all those times, my heart rate, it was checking everything. So let's assume I was a patient with problems in these areas. I could just download what this AI or whatever wearable thing has given me, that is in this case my phone, and just send it to my doctor that these are my parameters. Lydia Bolly. Then in the future, we are also thinking of virtual reality. Please, who has seen one before? Alberta, I will take you. I want someone to answer this before I continue. Virtual reality, that chair that we sit in, who has done it before? Oh, when you go to the malls, it's there, you pay money. Then you go, they'll wear it for you, you be sitting in it and you be screaming. Hey, you are boring midwives. Chim, mommy push, and you are done for the day. Please start going out. When you die, they will get people to come and do the delivery. So go out and enjoy yourselves. Okay. All right. So I believe by now you've seen what virtual reality is. It will be very good in mental health. Very, very good. In the sense that when we are talking about tranquility, we are talking about peace, we are talking about mental sanity, and probably we have a video of a serene environment of mountains mixed with a spring and falls and colorful birds and colorful fishes. In fact, as I'm telling you this, the way my head is being sweet, sweet, sweet. So imagine if they put that thing on me. They wear like a spectacle, and I'm sitting in a chair, which is moving me around. By the time I get off, even if all my troubles are not gone, 80% of them is gone. So for mental health therapies and rehabilitations, these are very, very good. So we plan to see them in future. All right. Then telehealth continues growth is likely to require policies to expand access, enhance digital literacy, and ensure equitable care, along with what? Sustainable investment models. When I was talking, I spoke about if you want reinvestment, then we would have to give you electronic receipts. So maybe in future, all these will come. All right. Let's look at advanced technologies. Sorry, advanced imaging technologies. I forgot my student, the one who raised her hand. What was her name? Is this Salah? Hey, there was a name. Where is she?
It was Alberta.
Yes, thank you. Alberta, where are you? Alberta, are you still there? Okay, so Alberta is no more. Probably the question she wanted to ask, I've answered it. And I also want to believe that Alberta's phone is somewhere. She's not paying attention. Alberta, that is a bad character. Okay, so let's go on. Is any class rep here? I want to ask something before I continue. Any class rep or
Yes,
anybody
sister.
can answer. Please, when is our class ending? 7, right?
15.
7:15.
7:15. All right, thank you. Okay. So let's see. What
Sister
are some of the
Alberta is back.
advanced?
Alberta is back.
Okay, Alberta, let me listen to you before I continue.
Sister, please, my phone, the screen has a problem, so I've been tapping it and it's refusing to lower.
Oh, I couldn't hear her.
She said it's the phone. The phone is having a problem, so she wanted to lower her hand. So meaning she
rather
wasn't
wanted to
actually
look at.
asking. Yes.
Okay, I get you. All right. So advanced imaging technologies have actually come to help us a lot. Hey, without it, what would we have done? How would you have been diagnosing sex of the baby? Presentations, of course, we would have done our best, but it would have come with so much error, like it's used to be with so much errors. So it has come to transform medical diagnostics and treatment, okay, by giving us detailed, sharp, accurate images of the human body structure and functions. And so, whom is it helping? Me and you. If it does that, it makes it easy for you and I to read and then diagnose. Do you get it? So we are able to diagnose, we are able to monitor, okay, and then give precise treatment. Okay. So some of them are common among us down here. Even we have seen a lot of them. Others too are not so common. It's enyeshe. Ibedru, so very soon we'll also have them. So we have the MRI, magnetic resonance imaging. Okay, we have the CT scans, the PET, ultrasound, and then right now we have AI-driven imaging techniques. Hey, I saw one on social media. I was like, what is the world turning into? They were using it to make prosthesis, and it beats my imagination. But however, it was good. It was nice. Okay. So let's look at them. Number one, MRI. We usually tell our clients, especially those with head injuries, to go for MRIs. All right. So in going for MRI, what is the client going to do? We say that it uses powerful magnetic fields and radio waves to generate detailed images. So this one, there is a level of magnetism, okay? They are also using waves, okay? Unlike ultrasound. Ultrasound is actually sound, isn't it? But these ones are using magnets and then waves, radioactive waves. And so because of that, it's not the best to be doing it every time, isn't it? Okay, it's not the best. When we want to use this, it's not always for bones. No, for bones, X-ray can even do a very good job. But X-ray doesn't do a very good job when it comes to soft tissues, okay, such as the brains, how do we call it? The spinal cord, muscles. Hey, me sincerely speaking, when I see X-rays, sometimes I get confused. Apart from the bones and then fluid-filled cavities which become ducts, the rest become like ash. Then for me. And so MRI makes the work easy. And then under that, we have the functional MRI, okay? It's also a type of MRI, okay, that measures actually brain activity. And those ones are very beautiful. When the picture comes, you see some places as blue, green, red, showing you the activities that, who is that? Oh. So it is valuable for mapping, okay, the brain function, particularly when there is neurological disorders, and when we are also planning to go for surgeries, we can use it before. All right, let's look at advantages. We are not cutting anybody. no blood, no fluid contacts. Just put the person in and you will see what is inside. Previously, everything you have to enter and go and see. And in entering, sometimes you cut what you are not supposed to cut, isn't it? For the distractions at my background. Okay, so like I said, it's non-invasive. You don't need to cut. No radiation exposure. Excellent soft tissue contrast. As you are making money. As in the picture that comes out, is perfect. All right. And then the ability to provide both another part that I like, so it's not just that it is functioning. The only thing is that it's expensive. Please, you are on the ward, help me. How much does MRI cost now? Who is helping me with that? MRI cost.
It's just that the last time I checked, it was 1,500 and some at Konfonochi.
Hey, how many people get salary of that much in a month? A lot of Ghanaians don't get that much as even a monthly salary. So imagine you telling such a person to go for such a procedure. Isn't it? Yes. It's also time consuming. What even kills me is how it moves slowly. I'm like, this thing, when will the person enter? And the discomfort part about me, hey, is those who are afraid of coughing. If you are someone who is afraid of coughing or being in enclosed spaces, okay, claustrophobic, I'm going to do this. And me, anytime I see it, the only thing that comes to my mind is putting them in coffins. Okay, it's scary if you have that kind of fear. And then if you also have metal implants, you can't go through it. You get it? You can't go through it because of the exposure you are having. The metal implant will react with whatever we are doing. And so, must you go for surgery for us to remove? That one too is another issue. Then let's go to computed tomography. We usually say CT scan, and off we are go. So what is CT scan? Using X-ray to create cross-sectional images of the body. So to some extent, CT scan is the big sister of you can't run away, man, isn't it? Yes. You can't run away so much from. It's actually what how do we call it? X-ray, which has been modified. So it's a kind of X-ray that we are using. Please let's admit that into our face. Okay. So this technique allows for visualization of bones, like I said earlier. When it comes to bones and then spaces filled with fluid, blood vessels have fluid. Yes. Standard X-ray, the normal X-ray we used to use, will do the work, but CT scan will do a better job. Then we also have the multi-slice one. Okay, these are modern ones which have come. They acquire multiple slices of the body Okay, please, so let me explain this well. You don't need to, how do we call it? Slice the body. No, that is not what we are talking about. What is actually referring to is the imaging technique, will bring it in sections. Do you get it? It won't just take one big part, pump, but it gives you the pictures in layers. What is the problem with that one? It uses radiation. That is it. Okay. And so you cannot be using it repeatedly. Its level of radiation is higher. Okay. And then the good thing is that it's quick and effective. It doesn't waste time like MRI. Okay. Especially traumatic events like cancers, injuries, broken bones, vascular diseases, is able to do it perfectly. Then we have the PET scan, which is the positron emission tomography. Okay, the PET that we even say PET scan. It is what? Positron emission tomography. All right, so this one is not computed tomography. However, I'll talk about it down here. There are some that you have PET and CET coming together. All right. So for PET alone, it involves injecting a radioactive tracer into the body. So you inject a radioactive substance into the body. So this is what it will do. Wherever you injected it, it's like a dye, you get it. When you take your scan, the color of that place will change. So let me say that we want to diagnose blockade or patency of a vessel or a tubal organ. When you inject, where it gets to, when you do the scanning, you would realize that where the radioactive agent or tracer got to, the color will be different. Then where it couldn't penetrate, we also have a darker color. Then you realize that, oh, so for this tube, from this place to that place, it's patent. That is why the tracer was able to what? Go through. Do you get it? Yes. So the scan would detect the gamma rays emitted by the tracer, just like we do it when we are giving dyes, to do some of these diagnoses, and that will create the image of the metabolic in there. So for the combination, sometimes we can have the PET and then the CT coming together, and that makes it more powerful because we know that the CT scan was giving us better anatomical of what metabolic information or processing, okay, how the functions are going. So in the case of cancer patients, the advantage it gives us is that you are able to see the parts of the body that has become proliferated or is cancerous. And after it being cancerous, what is the metabolic process going on down there? You are able to get that information. It is very, very sensitive in detecting cancer. Very, very. Once it's giving you the metabolic process, you would realize that if the treatment is working, you can pick it so that you know that, oh, this part is healing, this part is getting better, isn't it? Yes. So yes, you can use those ones there. But the challenge is what we've just spoken about. It's expensive. And then exposure to radioactive materials, the gamma rays which will be emitted and all that. And it's not a procedure that you can just go and do and come back home. Yes, you need to be in the hospital before the procedure, and then afterwards, you may need to stay there for some time to stabilize, and then you come back. Then we have ultrasound imaging. That one, dear sister, you know. Don't you know? Say, I know. All right. So in looking at new trends, okay, that have come. As for ultrasound, yeah, I know you are even doing it as a course. So let me allow you to teach me something. I'm coming to call somebody. Mercy ADJEI. Mercy. And Mercy, you have muted yourself. Unmute.
Sir.
Come and answer my questions. Mercy. So tell me,
Sister.
have you done ultrasound as a course?
Sister, no, please.
Hey, girl, aren't you doing it this semester or it's for next semester?
Next semester.
Not done it, please.
Next semester.
Okay.
So
So next semester,
True.
all right, I get you. Next semester, when you get there, take it serious because, Kelly, come on, imagine that there is an ultrasound scan machine at the labor ward. Labor is difficult. She's fully dilated. Descent is 0 feet. But this woman just can't push. And it's not as if there is low maternal effort. She's doing her best. So what is happening? You just draw the machine closer. You take a quick scan. Oh, only for you to realize that there's another problem somewhere. The cord is too short, okay, and that is what is preventing further further descent of the baby. So when you get that course, please do it well. You can even do part-time at some of these imaging centers for some small. Easy to buy rice for the house. Okay, so take it at your level. All right. So sound waves, I said it earlier on, sound like this in internal organs. It is widely used in obstetrics, that one we are familiar with it, cardiology, abdominal imaging, because all these places have what? Soft tissues. So with a Doppler ultrasound, this technique measures the flow of blood within vessels. So I have this senior colleague. In recent times, her feet is very much swollen, and her feet is very much swollen, and it is climbing up her leg. So she's always going for Doppler ultrasound, and they don't see anything. They wanted to actually find out if there is a blood clot, in the veins of the leg, but unfortunately, there is nothing. So these are some of the things. And we also need it, even in obstetrics. We want our clients to be ambulance to move around. Why? If you don't stop that nonsense, sorry, the children are distracting. Okay. So they want to find out. In our case, when they lie down, especially after delivery, especially even after CS for a long time, they are at risk of deep vein thrombosis. And so we have not passed this. We can actually still use it, the Doppler, okay, for our clients. Then what is the advantage? It's non-invasive, no radiations. The machine is even so portable, and then it provides real-time image. It doesn't give shadows. It gives you proper outlined image. The challenge is that image quality can be operator dependent. Yes, just like the way they go for scans. I remember some time ago, I went for a scan, and then the sonographer told me that I was carrying twins. I was like, "Eh, twins, pan." Okay. So I went to tell my doctor, gave the report to my doctor, and my doctor couldn't help laughing. She was like, "Where is the second twin? This guy, power boom." And what did he even say? He even said there was fibroid. And then what else? So I don't know how he was taking the images, especially when it comes to sex identification. All these are operator dependent. I remember one of my children, the pregnancy was just around 2 months, a little over 2 months. And then it was a female sonographer. She was a consultant sonographer. She told me that, oh, this will be a girl. I was like, a lot of people diagnose sex after 7 months. She said yes, after 7 months, because by then, vulva is real vulva. That is all. But at this stage, when it has just started forming, you do not have the requisite knowledge to determine that this will not be a future penis. It will eventually become a clitoris. This thing you are seeing will not be a labia majora. It will tend to become scrotum. If you do not have those knowledge, you will tend to give wrong information because it is what? Operator dependent and airfield stretches and lungs. Okay, so let me look at the time before I start the nuclear. Okay, so let's end with nuclear medicine imaging. Okay, so what we are actually looking at right now is single photon emission. So this one, we are not doing the piston, no. Okay, we are doing the single photon emission computed tomography. So we are not doing the piston emission tomography. We are doing single photon emission computed tomography. So of course, this one also uses what? Gamma rays. Yeah. And then they are radioactive traces, just like we learned. But at this time, it has gone a little above what PET can do. This one is giving us a 3D image. Not 1D, not 2D, but 3D. And 3D is like the real objects, isn't it? You all have 3Ds. Recently, I heard that there is a CT scan machine that is 3D. You can actually see the baby like you are holding the baby. Not those skeleton images they've been giving us. This one, you see the baby full rim, like you are holding the baby. You can tell whether the baby looks like you or looks like your husband or your grandmother. Let me use this to break the ice. Yesterday, I was watching this family court incidents in the US. And there is a man who has married for 50 years and wants DNA test of his 3 children with his wife that he has married for 50 good years. And that sounds ridiculous. After 50 years, You are now saying the children are not yours. So the lawyer asked him, upon what basis? One is a doctor, one is a teacher, and one is something. They are fully grown with their families. Upon what basis are you denying them? He said when he was young, he was very handsome and he married a beautiful woman. But the children they have are ugly. After 50 years. And then, secondly, one of the children has red hair. In his family, there is no red hair. And the wife said, but one of your uncles had red hair. He said that is a male red hair. His own is a daughter with a red hair. One of them doesn't have a nice nose. When he was young, he had a nice nose. To get a 3D sonography, know the kind of child you have, so they don't come and fight after 50 years that the child is not beautiful. If the child is not beautiful, you should see it in utero before baby comes out. Then let's look at how we are going to apply this. For the specs, we use it for cardiac stress test and brain functions, because of the tracer and how it's able to give a 3D image. Then it provides functional information about tissues and organs. That's another advantage. And then it involves radiation exposure. That one is a disadvantage. But the fact that it is 3D, it makes it beautiful. I'll be able to finish it. All right. So the network took me off. We actually ended. Someone said that the class has just ended. Yes, it was the network. It took me off and took off my slides. But because we have finished, there is no need to start it again. So let me take your questions. Let me take some 5 minutes to take your questions, and then we'll call it a day. All right. Ladies, I'm waiting. Let's pray before you even ask your question so that you learn here. Use it for your glory as we use it. Yes, Abigail, I'm waiting for you.
Good evening. Mr. Please, I want to ask, with the ultrasound scan, does it have any side effects as to the number of times a pregnant woman is supposed to take 3 times or 2 times, or she can take as many as she can?
Okay, so that's a good question. As research has evidence, the research evidence we have up to now, there is no trace of harm because it is not using radiation, it is using sound. So as we speak now, there is no evidence of harm to the baby or to the mother because there are no radiation. So she can take as much as she wants to. It's safe. All right. Abigail, are you okay?
Yes, I'm okay. Thank you very much.
Someone said, sister, please, why are we not using the technology to write our end of semester exams? Yeah. Mid-sem, end of sem, so NMC licensure, you use the technology for your exams, okay? So you have used it before. If we are going to use it to write your school end of semester. Then your class, you are over 1,005, isn't it? I mean, even ABC all put together, you are so many. So the university may have to be able to provide about thousand computers semester one of I don't like your results, maybe they didn't mark it well, maybe all next semester, and you can tell whether you have passed or failed. You get it. All right. So yeah. Are you okay? Who asked that question? Most people said their families do survive after MRI. Yes, because MRI doesn't have active radiation. So, of course, it doesn't come to destroy things like, how do we call it? The X-rays. Okay. I hope their families don't dream of, how do we call it? Being in coffins. All right. Any other question? So if there are no questions, we can call it a night. A very good night. Someone said, sister, please, how many days does it take for MRI results to be what? Hey, the message is gone.
To be ready.
Okay, I think it depends on the facility. Okay, it depends. Some of them, you go 1 week, 2 weeks, it will be ready. Others too are able to give the results early in some few days. So it depends on the facility. And sometimes the load of work they have. I know that one, you don't get it like print it for you, but it always depends on how efficient where you went the work. Someone said, please, sister, can a pregnant woman take it? Not good for the baby. Unless, of course, okay, depending on the condition you have, eat bed without any harm to the baby. I don't think any doctor will intentionally